Good morning. I'm Julie Tatesman, the OIG Chief Medical Officer, and I'm going to spend the next 15 minutes talking to you about the importance of documentation in patient medical records and in claims and bills. Providers have the responsibility to submit accurate claims to the federal healthcare programs and also to maintain accurate patient medical records to back up those claims. Now, documentation is important for three main reasons: to protect the programs, to protect the patients, and also to protect the providers. First, to protect the programs. Accurate documentation on records and bills makes sure that the programs pay the right amount, not too much and not too little, and make sure that we pay the right people. Second, protecting the patients. Accurate documentation in the medical records ensures that patients get good quality of care and promotes patient safety. And finally, protecting providers. Good documentation helps healthcare providers avoid liability and helps them keep out of fraud and abuse trouble. Now, today we don't have time to go into instruction on how to document the numerous different types of clinical encounters or how to code for all the different types of items and services that healthcare providers offer patients. Instead, we'll take the time to outline why documentation is important and provide some real-life examples of what happens when documentation is inadequate or inaccurate. Now, in OIG's oversight role, we have to make sure that claims are accurate so that Medicare and Medicaid pay properly. Through our audits, evaluations, investigations, and compliance work, we have identified lots of examples of inaccurate or incorrect coding and billing. Now, I'm going to list 7 common billing abuses. Now, I did this training in Kansas City, and I just rattled off the list without giving numbers. And folks, their eyes glazed over, or people with iPhones started playing Angry Birds. And one of my colleagues gave the same session in Denver, and she gave every one of these billing violations a number, and this amazing thing happened. People took out their pens and they wrote it down. So I will give the numbers. There are 7 common billing violations I'm going to talk about. The first one is upcoding, and that's billing using a more expensive code, a code for a more expensive item or service than the service you actually provided. Second is unbundling, and unbundling means billing separately for services that are properly grouped within a global fee, like a global surgery fee. It would be unbundled if you billed the 2 different codes for the surgery and then for the follow-up visit the next day. Lack of medical necessity, and that's billing for medically unnecessary items or services. Now, it might seem obvious, but Medicare and Medicaid shouldn't pay for items and services that patients don't need. Now, this holds true even if the item or service was provided. So a real wheelchair is provided, but to a patient who doesn't need it, then Medicaid shouldn't pay. The same thing if an MRI is delivered, but a patient doesn't need it, even if the MRI is competently performed and interpreted, if the patient didn't need it, it's medically unnecessary, and Medicare and Medicaid shouldn't pay. Fourth, billing for services not rendered. That's pretty simple. That's billing for things that you didn't really provide. 5 is worthless services, billing for services that are of such low quality that they're virtually worthless. 6 is duplicate billing. That's billing twice or even more than twice for the same thing. And then 7, lack of documentation. And that's billing when the medical record can't back up the claim. Now, healthcare providers' bills must be accurate. You have to use the right code, not just the code that offers you the best reimbursement. If you don't know how to properly code a service or how to claim reimbursement, then ask someone you trust. Now, good documentation also promotes patient safety and helps ensure quality patient care. That whole absent-minded professor thing, I'm a good doctor, I'm just really bad at paperwork, OIG finds that excuse neither charming nor persuasive. Failure of documentation is more than just a technical paperwork problem. It can actually endanger patients' health. Good medical record keeping ensures that patients get the best possible care, not only from you, but from other providers who rely on your medical records when they treat your patients. Accurate record keeping prevents subjecting patients to unnecessary services or duplicate services and avoids harms like giving patients a drug for which the patient has a known drug allergy that should have been clearly documented in the chart. In short, bad things can happen to patients if the medical record is not accurate. In recent years, healthcare delivery has become increasingly complex. The sheer quantity of data recorded in patient records is growing. and patients are often seen by many different professionals. Clinicians can no longer just rely on their memories for patients' past medical care. It's very important that the documentation in the record be complete, accurate, and also legible. Any providers in the audience know how frustrating it is to look at a scribbled note or a scribbled order in a patient's chart that has information that you know you need, but you can't read it. So it's very, very, very important also that the record be accessible to the team and promote communication to the different providers who are caring for the patient. Now, I said that it's important that the record be accessible for the care team, but it should be accessible only to the care team. Only staff who are legitimately treating the patient should be able to see the record, and providers should have good security systems in place to prevent unauthorized access to medical records. If done properly, good documentation can be a central tool in clinical decision-making. Now, we've already talked about why good documentation protects payers and patients, but it also protects providers. Providers have paid stiff penalties for coding violations. To give an upcoding example, an endocrinologist recently paid almost $500,000 for upcoding routine blood draws using the higher paying code for critical care blood draws. In another example, a dermatologist paid almost $3 million for falsifying diagnosis codes. What he did was he billed as if his patients had a certain disease that's covered by Medicare, when in fact they had a different condition that's not covered by Medicare. And that dermatologist was also sentenced to 2 years probation and 6 months house arrest. Now at OIG, we believe that most providers are honest, and the government generally does trust providers. But for oversight purposes, we do sometimes check the medical records to make sure that they support the claims that were billed. If your claims are selected for review, a clear and complete medical record will help your claims withstand scrutiny and make sure you get them to keep the money that was paid by Medicare and Medicaid. A few tips to remember. When OIG reviews the legitimacy of claims and services, we must take the position of if you didn't document it, it didn't happen. Clear information showing your rationale performing a diagnostic test helps demonstrate that the test was necessary and will help you meet the medical necessity requirement. Clear documentation of test results helps substantiate that the test was completed and will also help substantiate the need for subsequent care that might get later billed to the programs. Now, in one of our ongoing studies, we are looking at imaging services that were billed to Medicare for beneficiaries who are treated in hospital emergency departments. Now, many of those records that we're seeing are excellent records. They're legible, they're complete. They have a history and physical showing why the patient got the imaging study. They have results of the imaging study, and they explain then, how the results were taken into account and what the treatment plan for the patient was based on those results. Those records fully support the services claimed, and those hospitals and those physicians don't have to worry about Medicare coming and knocking on their door and asking for the money back. But those aren't the records I'm going to show you right now. This is an ER record for a patient, and the hospital billed Medicare for a chest x-ray. But all we see in this record is a chief complaint and some vital signs. There's nothing about that chest x-ray that Medicare was billed for. In another record from the same study, we see a similar ER record, but it's even less complete. The only thing written on the whole page is 3 letters, and that's CXR, an abbreviation for chest x-ray, in the order section. And there's nothing else in there to indicate that the patient needed a chest x-ray, that the patient got a chest x-ray, or that anyone actually read the chest x-ray and used it in treating the patient. Now, in a post-payment review, when claims are not supported by documentation in the medical record, providers may have to repay Medicare and Medicaid for the money that they received. Now, generally, most claims are processed automatically, and then, if necessary, subject to retrospective review. But that doesn't have to be the case for all providers. To mention one really useful oversight tool, for suspicious providers, CMS does not have to automatically pay claims. CMS can place suspicious providers on prepayment review when they have reason to suspect fraud or abuse. Going forward, you should be aware of an increased enforcement of documentation requirements. I can point to several reasons for this. First, the administration is pursuing an initiative to cut the improper payment rate in Medicare fee-for-service in half by 2012. Second, OIG has recommended that CMS and contractors focus on error-prone providers. And CMS is increasingly tasking contractors, those MACs, RACs, and CERT contractors that James and Nancy talked about, to review medical records to prevent improper payments. Now, currently, many healthcare providers are adopting electronic health records, and this can be a great thing. It can be great for providers by increasing practice efficiency, and it can be great for patients by improving patient care. However, as providers adopt these new technologies, we hope that they will watch out for certain vulnerabilities. Two related areas of concern are cloning and over-documentation. Some electronic health records make it really easy to clone and to over-document. Cloning is basically cutting and pasting. It allows you to cut and paste information across different patient records or for the same patient from visit to visit. Other systems facilitate over-documentation. They might have default settings where they automatically fill in full history and physical or full exam and full review of systems for every patient and for every patient visit. And then those systems, if the provider didn't render that service, the system requires the provider to manually uncheck a box or delete an automatically filled entry, rather than making the provider actively fill in what they did provide. And we urge providers to remember that it's just as dishonest to let a computer record that you provided something you didn't as it is to write it by hand in a paper chart. Now, one potential advantage of electronic health records is that they can allow multiple professionals to use and look at a patient's record at the same time and from different locations. The flip side of this accessibility, though, is security. In many hospitals, you might see signs in the cafeteria or in the elevator warning the staff not to talk about patients in public areas where they might be overheard. Electronic health records raise additional issues of electronic eavesdropping. In some of our information technology audits, we have OIG auditors who will sit in the parking lot of a hospital with a laptop computer and drop on to the hospital's wireless network and actually be able to access patient information that's supposed to be private. As healthcare providers, you have an obligation to make sure that your systems are secure and make sure that people can't do that people can't gain access to your patient's private information. Now, many electronic systems also give providers convenience, allowing them to access patient information from home or on personal digital assistants, wherever they might be, to check lab results. This can be a great thing to provide more timely care. But again, it's important to make sure that your staff, if they're using electronic device that's either not owned by the hospital or not controlled by the hospital or the healthcare provider, to make sure that you have good security for the data on that device as well. Now, good electronic record systems also have good integrity functions, like functions that track which users access the system, or functions that apply the actual date that an entry was made, the actual time, and the actual author. Now, some systems unfortunately lack these important record integrity features, or they allow users to shut off those features. Now, sometimes providers do legitimately need to change medical records. If you're working on a record and you see a progress note that has wrong, bad information, you legitimately need to correct that information so that another provider who's treating that patient won't rely on wrong information and provide the wrong care. But when you want to make a change to a record, you must always sign and date that change. You should never try and slip in new information to make it look like it was made at the same time as the original entry or by the same author as the original entry. Now, this record on the slide is from an audit that we conducted to see if Medicare payments were appropriate. We raised this beneficiary with the provider because the Medicare program was paying as if the patient had chronic renal insufficiency, but our auditors didn't see any record of chronic renal insufficiency in the patient's chart. Now, the provider, when questioned, responded and said, well, the patient actually does have chronic renal insufficiency, and the provider directed our attention to this page of the medical record and the highlighted letters to support the diagnosis. Now, let's focus on that section. It says chronic pain, pathology diagnosis, CRI, an abbreviation for chronic renal insufficiency, renal cell carcinoma, refer to oncology. And now CRI is highlighted in yellow. I should note that the highlighting was done by the provider, not by OIG. There's no notation on this record to indicate that anything was added later. But now, our audit team already had this page of the record. But in the earlier copy, it just says chronic pain, pathology diagnosis, renal cell carcinoma, refer to oncology. So CRI was added later. It wasn't added at the time of this note. It wasn't added when the patient was seen. It was at a later date, actually even after this record had already once been copied to respond to the audit. Now, some electronic health records will allow providers to slip in things like this, and others won't. I can't think of a legitimate reason why a record system should help a provider backdate or postdate a note or an order. So if you're selecting electronic health records systems, I hope you'll pick one with good program integrity features. If you have to use an electronic health record system that would allow you to falsify authorship or actual entry time or date, don't use that feature. If the system allows you to turn off audit features, well then don't. Some systems will actually allow you to keep a note or other entry in draft form for weeks, months, or even years. And then when you push finalize on the entry, the system backdates all of it to the date of the original patient visit or the date when you first started the note. And the system makes it look like you had entered all that information on that day. And some providers then intentionally keep their notes in draft form for a long time to give themselves the flexibility of changing notes later and making it look like it was contemporaneous. You must never use such features to obfuscate when you actually entered information in the medical record. Now, if you should discover that you billed for something like chronic renal insufficiency, but the medical record doesn't indicate that the patient ever carried that diagnosis, it might be tempting to just add CRI somewhere where you see some empty space on the chart. But the cover-up just makes it worse, which leads to our next discussion of better ways to respond to OIG requests for information and better ways to handle situations when you discover that you receive payments that might not be justified. So I will now turn the podium over to Tony Maida, a Deputy Branch Chief in our Office of Counsel, who will discuss OIG subpoenas, audits, and surveys, and the provider self-disclosure protocol.